Well, good evening, everyone. Thank you so much for being here. We'll probably be a little more casual than we have in the past because it's our last of the 4 events within this series. Our first 2 events were on residential segregation and then environmental justice. And last night we were talking about expanding democracy through voting. And tonight we're talking about equitable access to care. So thank you for being here for this 4th in the series. I am not Melissa T. Kirshner. I am Mark E. Kirshner. But we just, again, want to welcome and thank you for being here. I'm going to talk a little bit about what we're going to do tonight in the experience that we're going to try to create. And one of the first things, the other thank you, is to thank all of our sponsors. This is the biggest event that White Voices Against Racism has put together, and in doing so, it required a lot of help and a lot of partners, and these are the folks that helped out with making this all happen, all 4 events, and we certainly appreciate it. So, at each of our events, we've done the Social Justice Bazaar. I very much feel like community and building relationships is part of this work. Understanding and getting to know each other is extremely important, and the fellowship time that we have before and afterwards, just a little bit, is all part of that. So thank you for getting here a little bit early and taking advantage of that. The 3 main things that we're going to do tonight is learn, engage, and act. So we're going to ask you to learn a little bit about the topic. Then we're going to ask you to reflect and talk about that. And then we're going to ask you, what can you do to help in this particular area that is part of systemic racism. And then we can be back out front there for a little bit more fellowship after that. So I'm going to start the learning portion of the evening, and we're going to have 2 speakers that are part of that, which I will introduce and bring up in a moment. But first, we're going to have just a little video that is a primer to help explain what health equity actually is.
To better understand the goal of health equity, you need to learn what causes health differences among groups of people. Health inequities are differences in health that are avoidable, unfair, and unjust. Social, economic, and environmental conditions can affect health in a number of ways, creating health inequities. Social inequities occur when a person is treated unfairly because of things like race, class, gender, sexual orientation, or immigration status. Institutions, such as corporations or schools, have the power to create unequal opportunities based on social status. These unequal opportunities can lead to poor educational outcomes or fewer job opportunities, creating economic disadvantage. For example, a college graduate earns over $36,000 more per year than someone who did not finish high school. Income can determine the neighborhood you live in. The environmental conditions of a neighborhood can affect a person's health. In Marin, California, someone can live 15 years longer than someone who lives just 8 miles away. Why? Lower income neighborhoods tend to be in poor social and environmental conditions. Examples include being closer to environmental hazards, such as freeways or power plants, having higher crime or violence rates, or limited access to healthy foods and safe places to exercise. Social, economic, and environmental conditions can affect health disparities, which are differences in health among groups of people. Health behaviors affect disparities. If people are not educated on how to lead a healthy lifestyle, or they lack social and financial support to make healthy choices, they may choose certain behaviors over others. Behaviors such as smoking, poor nutrition, or unsafe sexual behaviors increase chances of developing chronic conditions or diseases, which can affect how long someone lives. Smokers live at least 10 years less than non-smokers. Health disparities are also affected by genetics. We are learning more every day about how our genetic makeup makes us more vulnerable to certain health problems. Access to quality healthcare is one key in reducing inequities and disparities, but health is more than just disease or illness. Health is how we treat others, the opportunities we are given, where we live, and our everyday behaviors. Nobody should be denied the chance to live a long, healthy life because of social, economic, or environmental conditions. To achieve health equity, we need to eliminate avoidable health inequities and health disparities. We need to create fair opportunities for health, provide equal access to resources, and invest in low-income neighborhoods. Health equity will be achieved when everyone is able to reach their full health potential.
All right, so I'm going to introduce our first two speakers for the evening. And speakers, what I would ask you to do is when you first come up and start your presentation is take a few moments to tell us a little bit about yourself, something that you would want the audience to know. It could be related to your presentation, it might not be. So that's going to be your official introduction. So our first speaker is going to be talking about equitable access to care, Dr. Olu Jegede, and he is with the Clinical Care Equity Unit at Cone Health. And then Jean Elms, who is the program manager for Every Baby Guilford, is going to talk about that program and bring in a little bit of the practitioner side. Again, if you've been with us before, we have the practitioner that is talking about working within that field itself. So with that, I'll ask Dr. Jegede to come on up.
Good evening. Can you hear me, or do I have to use the microphone? So thank you for inviting me to speak with you this evening. Thank you for all that you do. This is one area that is a passion of mine, and you will know why that is shortly. But before I get started, my name is Olu Jegede. It's a very long name, so that Olu is actually in Nigeria language it means God. But I don't want you to call me God. So the full name is Olugbemiga Jegede. And Olugbemiga means God has lifted me high. So Gbemiga is lift up or lift high, and Olu is God. So, but because of convenience and easy pronunciation, I think Olu is just what everybody calls me. So okay, you call me God. Well, fine. That's fine. So I'm from Nigeria. I've been here for, gosh, I don't remember, but it's been a while. Spent 2 years in Canada after immigrating out of Nigeria, and came to US 2007 and did my internal medicine and pediatric residency in Flint, Michigan. 4 years program, stayed there for 3, and then came to North Carolina. And I've been with Cone Health since 2014, working in area of underserved and uninsured and underinsured patient population. So just briefly, when I was in Flint, I was sharing with some friends out there that it was a shock for me, because one of the things about coming to America, from a place like Nigeria that is a third world country, what we used to see on TV is what we believe America is. Like everything is fancy, flamboyant. As a matter of fact, we thought nobody is sick, so why are you going to America to practice medicine? That everyone is, like handsome and beautiful, and it's like, Chicago, beautiful high rises, New York, LA, everyone is happy and bubbling, and everything is like Hollywood. And then when I came to Flint, it's like my city is better than this, and I began to see the differences, how people are treated, began to see disparities in outcome, And I began to see different things, like when the uninsured come to the hospital, they don't have a doctor. So they get admitted to the hospital with a bridging order from the emergency room. And then the nurses carried out those orders until patient feels, oh, yeah, I think I can go home now. And they go home to the same thing. No follow-up, probably no medications. And in 2, 3, 4 days, they are back. So one of the things I was opportune to do after my residency was to start what we call academic hospitalist, to see exactly this patient population. And we partner with an FQHC in town so that when they are discharged from the hospital, they follow up. And then things began to feel a little better, and we reduced their ED visit. Outcome became slightly better. And I think if they continue that program, it should really make a difference in people's lives. But coming to Flint was to really scale that up and be in the outpatient, want to be that doctor that people will come and see when they are uninsured. And that's what I have done for 10 years at Cone Health. So today, I want to, kind of just go through how all this thing really happened, And I will start with a quote that you are probably familiar with. This is a quote from Dr. King, very long time ago, but it's still true that of all forms of inequalities, and I would dare to even say of all forms of inequity, that injustice in health is the most shocking and the most inhuman because it often results in death. It is very harmful to have inequity or inequality in health or healthcare. Let me introduce you to this patient, or this beautiful woman. I will call her name Takia. So Takia was 32 years old when something happened. She has lived all her life really healthy, no doctor's visit, and all of a sudden she started feeling something fluttering in her heart and some kind of just feeling unwell and feeling a little anxious. So she went to the emergency room and they thought, okay, your blood pressure is a little on the high side. Why don't you, calm down? Maybe you are anxious. They gave her some medicine to calm her down with the diagnosis of anxiety and discharged her to follow up with her doctor. 6 months later, she had the same thing. Then she went back to the emergency room. This time around, her blood pressure was higher than the first time. So they say, you know what, maybe it's blood pressure. Maybe you are hypertensive. You have high blood pressure. So they gave her medications, prescribed medication, and told her to follow her doctor. Now she had 2 diagnoses. She had hypertension, she has anxiety. So she's on 2 medications, one for blood pressure, one for anxiety. That was 32. About 2 years later, Takia came to the hospital, also emergency room, but emergency room for pregnant women. She has not seen a doctor for this pregnancy. She was heavily pregnant at 36 weeks of gestation. From that emergency they call MAU, blood pressure was through the roof. Baby was showing some non-reassuring signs, so they could not even wait. She was wheeled directly from that emergency room to the OR, and she had an emergency cesarean section. And she had a baby. Fortunately, baby was in the NICU for about a few weeks. And she was in the hospital for severe preeclampsia, that is blood pressure associated with pregnancy, and was treated for a prolonged time in the hospital. But fortunately, too, she got better and was discharged home to follow up with her doctor. Now, no one saw Takia again until about 2 years later. Now she was 36. And for some reason, she has gone to an eye doctor, maybe for a job or something. And the doctor who was looking into her eyes told her, you have to go to the hospital immediately. It's like, what happened? It's like, you already have problem in your eyes. And this is something that happens when you have blood pressure after a very long time that is uncontrolled. You have ruptured of those tiny vessels that is behind the eyes, and you can actually go blind. We call them cotton wool appearance. So that's what they saw. They sent her to emergency room. She got there. Blood pressure was about 220/140. Gave her prescription and told her to follow up with her doctor. 2 weeks later, her mom called that Takia had passed away in her sleep. 2 weeks after she had seen a doctor in the emergency room. So when we talk about outcome, high blood pressure is a chronic disease, but it's manageable, that a lot of people can actually live with it if they take medication. And if they see their doctor regularly, get checked up. But Takia died at 36 because of blood pressure. And I almost said, I think we should go home after that video, because it covered everything, that about health equity. Health equity is the principle that everyone, we did not say whether you live here or live there or white or black or whatever, everyone should have a fair and just opportunity to live as healthy as possible. Everyone. Now, there is a difference between that and disparity, which is the differences in the status that is closely linked to disadvantage. And I will just tell you, there is reason this happens. And I think we all have an idea of how it happens. So why don't we just review it together once more? And I'm going to use what Dr. Jones is one of the public health, expert, She used this analogy, and I love it. So if you look at this, you'll see a lot of people, it's a platform that's level of health intervention. And the cliff, you can see like you can drop and fall down. So what this means is you were born, and then you grow slowly, then at some point something is going to happen, you're going to fall off the cliff. And the prayer at that point is maybe something holds you so you don't fall all the way to the ground, or when you fall all the way to the ground, hopefully there's an ambulance there to take you to the nearest hospital. But if there is no ambulance, then what happens? Or if this net, we call safety net, all those things, they have holes in them, which means when you are falling, if you are the ones that are uninsured or underinsured, you're going to fall through that crack. So the system is designed in a way that there are different levels where we need to intervene. This is a normal cliff analogy. So you are talking about people going, and then when they fall, you have safety net. Those are the clinics where they can be seen and taken care of. When they fall all the way ground, how can they be taken care of in the hospital? Now you would think that, why do we even let people fall? Why don't you put a fence so that people don't fall all the way? Well, you can do that, and some people have done that, but the problem is you are talking about population. So if the population is really heavy, they can push the fence, and people will still be falling. Now, the problem with this analogy is that it doesn't cover everything. It's not the whole story. It's actually, and that is what the video was all about is actually a three-dimensional cliff. You see, some people are at advantage on the other side, some people are disadvantaged on this side. So it's a three-dimensional cliff. Even if you put fence on this one, fence on this, and everyone is there, you have ambulance on the floor, on the ground. Sometimes the ambulance on the other side may have a flat tire and may not be able to convey people to where they need to be. Or there is no safety net, or there is no fence. Or they are born in an environment where they already push very close to the cliff, whether they are young or, Takea fell off the cliff at 32, and she died at 36 of a very preventable disease because she fell through the net, and when she got down, there was no ambulance. So these are the three major interventions. That is determining health. So this is the determinant. So you have differences in quality of care, you have differences in access to care, and differences in exposures and opportunity. So now we have differences in quality of care. Can anyone say what's wrong with how we managed her care? Even though she kept going to the hospital, she was seen. We gave her medications. We told her to follow up with her doctor.
Well, what doctor did you follow up with? Was there warm handoff to the doctor?
Nobody knows that. Did we even know if she had a doctor?
Right.
Did anybody even find out if Takia was able to buy those medications we wrote for her?
Understand how to take the medicine.
Understand how to take the medication. So the quality of care she got is different. I'm not going to say it's bad. And then the access to care, because she kept going to emergency room. She had no doctor. And then the exposures or the opportunities at the environment where Takia lived. Maybe she's so scared, so probably she really have anxiety. Maybe there's something driving, even though she had blood pressure, maybe running the family, but she still has a mom. So something is driving her own hypertension. You talk about institutional racism. That is what is perpetuating this. This is 2024. I came to US in 2007. We've been talking about this thing, and I know years before then they've been talking about inequity, racism, and everything, but it keeps happening. We know about redlining. Well, some time ago, we were having a conversation. I mentioned redlining. Somebody asked me, what is that? And I'm like, wow, okay, so maybe we have to start all over again, We have housing policy. We have all these policies that are linked to health outcomes, linked to poor health outcomes. And then when you get to the health system, there's also disparity in how you are cared for. There's a lot of statistics I can share with you about some people who are not getting pain medication because they don't believe they have pain. Or when you are, maternal death, I know you're going to talk about it tonight. Or infant mortality. Do you know that Guilford County has higher infant mortality rate than the rest of the country? 2 to 3 times higher for black baby to die before their first birthday than the white babies. Food, they say food is medicine. How can we be a first world country, superpower, and some people go to bed hungry in this country? It baffles me that you have kids, they're not able to go to school because there's no food to eat. And all these things are being perpetuated by institutionalized racism in health and healthcare, in institutions, in structures, everything. How many of you have seen this before? This is also a very popular slide. So we are talking about health outcome now. It comes with the length of life and quality of life. So it's 50-50. But you see, the whole health outcome is only 20% that is dependent on the health system. The all others are social drivers of health. So you are talking about education, employment, income, family and support, community safety. Those are the social drivers of health. The clinical care, which is dependent on the health system, is only 20%. And that is why I'm so glad that United Way is here tonight, because we really need to give priority to economic vitality. This environment where their exposure and to opportunities or lack thereof, we need to go there and help them. I believe that's why you are here tonight, to know what can you do. There are people that have been left behind. So if you see, this one is, equally weighted. 1 second. I'm sorry. Something has happened. Okay. Equally weighted, 20% healthcare and quality. We have access to education, you have neighborhood and built environment, you have social community context and economic stability. Those are the things. So 80% is in other areas. And that is where you can come in. If you don't work in healthcare, it does not mean you cannot impact health inequity. Everyone has to have, all hands have to be on deck. If you can help with community context, if you can help with built environment, reduce crime, you can help with economic vitality, or even access to quality education, all those impact health outcome. I don't know Takia's educational level, but if she was educated, maybe she would be empowered to ask questions. Well, I don't have a doctor. When you say follow with your doctor, or I don't actually have money to buy my medication, can you help me? You know. This is Greensboro. If you look at this, at the middle of this map is Moses Cone campus. If you drive 5 miles north on Elm Street, how many of you know Elm Street? It's a popular street here. If you go up north 5 miles, the life expectancy there is about 85 years. You come back to Moses Cone and drive south on Elm Street, it's only 70. We are there now. This is this environment. So, and you drive from this bubble to the other bubble, it's also 15 minutes drive. So you lose 15 years in a 15 minutes drive within the same city. And that is from the health need assessment, the community health needs assessment. So how does this happen in an environment where everyone thinks things should be moving on? You have people who cannot, just because of where they live, they are not allowed, they can't attain optimal health. I said I'm from Nigeria. Nigeria is a third world country, a lot of poor people, lots of, the disparity is like if you have money, you have access to everything. If you don't have money, you may live in the best city in the country, you don't have access to anything. So that is the gap. It does not depend on where you live, love, play, or pray. It depends on if you have income or not. But in America, it's different. Where you live actually matters. Somebody said your zip code is now more important than your genetic code in determining how long you live. I just think that is not acceptable. Something does not sit right with me. Did you see anything common to these slides? It's the same area, right? The same area where we are right now. If you look up on the top left, that is where the life expectancy, that's the map, where people are dying young. Social vulnerability index, the same place. If you look at the people who they have teeth loss prevalence, very high, the same place. Overweight and obesity, the same place, the same place. You're talking about kidney disease. People are having end-stage renal disease on dialysis, same place. Stroke, same place. Disability rate, of course. Per capita income, very low per capita income. So this is telling me that geographically, where you live actually determines how long or how well you live. When I practice at Community Health and Wellness, most of my patients will be coming to me for the first time seeing a doctor after they've had a life-changing event. A lot of the time, it's after they were discharged from the ICU for stroke, for maybe heart attack, for something has happened. And they say, oh, they say I should come and see you. Then what's going on? Well, I had a heart attack. Wow, okay, so what can we do for you? We do all the labs. Hemoglobin A1C, which is the measure of diabetes, is 15%. Normal is around normal is below 6. So you see 15, and then we have to walk with them and hold hands and get medications until we get back to where they need to be. Because anything above 8, you are on your way to dialysis. And you see, sometimes they come and say, I remember this patient will ask me, doctor, I hope you're not going to do my blood test today. I'm like, we have to do it. It's been 3 months. It's like the last time you did my blood test, I got this bill, and I got taken to collection, so I don't want that to happen to me. I'm like, how does that happen to people? I will see patients, they will be so happy. Hey, Dr. J, I now have insurance. I have Medicaid. So I guess I have to leave you and go look for doctor. Because because I see uninsured, they think, yeah, now, the level has changed. You have to go look for doctor who will take their insurance. Unfortunately, after 2-3 months, they come back. I'm like, what happened? Oh, well, I just found out that because of my insurance, I had to do all this copay, but when I was with you, I didn't have to pay anything. So every level, there's a problem, and people are dying. For all the policies and all the things that we do, we are making it so difficult for people. When the health need assessment came out and we saw the life expectancy disparities, we took a deep dive into our own data to see why are people dying. These are the 5 major drivers of life expectancy in our areas. The first one you see here is the cardiometabolic disease, which is high blood pressure, high blood sugar, stroke, and smoking. Cancer, I remember you were mentioning that cancer is a chronic disease. Cancer, because a lot of our patients' populations, especially the area we're talking about, they don't get screened on time. We're talking about breast cancer screening, colon cancer screening. And again, because of stress and everything, smoking prevalence is higher. But again, if you know that you can be screened for lung cancer, you may be caught at stage 1 and you can have chance to live, but because people don't know or they don't have awareness or they lack access, by the time they're coming stage 4, and that's like death sentence. prostate cancer, colon cancer, cervical cancer. All those are the ones killing people here. And the one I highlighted is infant mortality, which is closely related to maternal morbidity and mortality as well. So you have the two on the sides, the homicide or unintentional injury and opioid overdose. Those are the things, those are top 5 killers, top 5 drivers of life expectancy in our area. At Cone Health, we have what we call Catch 5 in 5. Have you heard of Catch 5 in 5? So Catch 5 in 5, the catch stands for collaborative actions toward community health. And the 5 in 5 is we think we can take on this life expectancy disparity and reduce the 15 years gap by 5 years over the next 5 years. And 5 years because for cardiometabolic disease alone, if we focus on hypertension, diabetes, smoking, and overweight or obesity, if those 4 were reduced or controlled for everyone that needs to be controlled, you will have 5 years back to your life. So those are the initiatives that we're carrying on now. We're going to work with you all, with the community organizations, to make sure that we get that. We're working with everybody, Every Baby Guilford, on infant mortality and maternal morbidity, and you're going to talk about that today. And like I said before, this is health and healthcare. That's where we are. But we really have to partner with United Ways, with other community-based organizations on all these other 3 because they are equally very important. All right, so we talked about this before, but I'm bringing it now back home. Like, how do we address those social drivers? It's not going to be healthcare alone. It has to be the community. Because as you know, health and wellness resides in the community. It's not in the hospital. By the time somebody comes to the hospital, it is already a failed system. People should be home. That's where health and wellness is. And then when you come, you are coming to get checked out, you're coming to have screening, and if there is blood pressure, of course, you are home, you just come to get your medications and go back home. But because of all the stress in the environment, all the stress in the community, all the poverty and no housing and experiencing homelessness and no job and no school education is low quality, all those things put together, putting stress on the community. So that if you have diabetes, you have to decide, okay, do I want to buy my insulin or actually eat? I have patients making decisions on, do I put food on the table or do I go buy my medication? I share a story about a story I heard about a mother who had to decide if she has a son. She had to decide if she should get food for the son or buy inhaler. This boy had asthma. She can't watch her son die of hunger. So she took a chance that maybe he's not going to have any attack. So let me buy food. Bought food. They ate it the first night. The second night, he had an asthma attack and died. So these are the things that we need to confront as a team. Like, how do we allow this to continue to happen? It is killing people. Inequity is harmful. I have physicians that I talk to many times, and they will say, "Oh well, I treat everybody the same. I don't see color. I don't see color. I'm color blinded." Well, I want you to see color. I want you to pay attention to me. I want you to see me. I want you to hear me. I want you to listen to me. Care for me. And don't treat me like everybody else. When Takia got to the emergency room, they treated her like everybody else. We assumed, like everybody else, she had a doctor. We assumed, like everybody else, she can buy medications. We assumed, like everyone else, she had transportation. And all that, maybe she had none of that. But we did not see her. We treated hypertension. And even that is equity, right? But how about justice? How about just remove all the barriers? Remove the redlining. Let everybody have access to everything. Let everyone have access to sidewalk. Let everyone have access to transportation. You know, you have an appointment with your doctor tomorrow, but there is nobody to take you there, and you can't drive, or you don't have transportation, or you just suffered a stroke and you are not allowed to drive, and nobody's going to take you. Then you're going to have another stroke. So I call this Takia story reimagined. There's a lot of things that needed to happen at community level and at the hospital level. But this is just about the hospital level, and I'm talking about cultural humility. That is all it takes to understand what Takia was going through. Questions: do you have a doctor? Question: do you have transportation? Do you want us to get you an appointment? Do you even know where to go? And if you get the appointment, how do you get there? Can we connect you to somebody at the community level, like a community health worker, who can hold your hand and take you to, maybe you need food, transportation, housing, or all those kind of things that is causing stress? Can you afford your prescription, or do you want us to get you? We have Dispensary of Hope. We have other people now coming up with ideas on how to help patients get their medication free of charge. And then do we connect Takia, maybe she was overweight, to some fitness centers, some insurance plan. Maybe she even had a job, but she doesn't know that she qualified for Medicaid. We can help all these things. But because we are so pressed and because we want to treat everybody the same, we forget that some people need that extra length to be cared for. And if we had done that for Takia, she would have been alive today. That baby would have been 4 years old, maybe in the nursery school, happy and healthy. She will probably be about 40 years old now, because that story was a long time ago. And everybody would have been, at least, that would be a success story. These are the things that we need to confront, the uncomfortable truth, that health disparity is harmful. It causes unnecessary and excess suffering. It leads to poor outcomes. It kills people. Like Dr. Martin Luther King said, injustice in health kills people. It results in death. And it is very expensive. Health equity is a human right. You should not be talking about, oh, well, these patients smoke. You have money to smoke, but you don't have money to buy your medication. How dare you? But that is not the point. We don't know the whole story. Advancing equity is a journey, it's not a destination. We must continue to be vigilant, and I'm thanking you for being here because I want you to do that, spread the news, and also confront institutional racism. It is the one perpetuating health inequity, and it's killing people. So I challenge you to be mindful of the narratives, and let's refrain from stigmatizing communities. Oh, they are very lazy. They just don't want to work. That's why they are poor. That's why they don't have housing. That's why they beg on the street. You don't know the story. We need to be empathetic and make sure that we put ourselves in their shoes. Demonstrate empathy. Emphasize that health equity benefits everyone. When East Greensboro is profitable and flourishing, Northwest Greensboro will be at peace and they will also flourish. It's not going to diminish anything for them. But as a matter of fact, they will probably be safe. Because when these other people are, no job, no money, poverty, and crime rate goes on, it affects everybody. And I want at your organizations, please assess where you are. What's your current state? What are you doing about inequity? How are you messaging it to people? How are you helping to remove structural and institutional racism? How are you confronting it? It's not just okay to talk about it. We have to do something about it. You saw the cliff analogy. This is a poem that was written in 1913, actually in this North Carolina. I'm going to read it to you now. It's talking about the cliff. It said it was a dangerous cliff, as they freely confessed, though to walk near its crest was so pleasant, but over its terrible edge there had slipped a duke, and full many a peasant. So the people said something would have to be done, but their projects did not at all tally. Some said, put a fence around the edge of the cliff, and some said, put an ambulance down in the valley. And the poem ends like this: better guide well the young than reclaim them when old. For the voice of true wisdom is calling. To rescue the fallen is good, but it's best to prevent other people from falling. Better close up the source of temptation and crime than deliver from dungeon or galley. Better put a strong fence around the top of the cliff than an ambulance down in the valley. That tells me prevent people from falling down. Prevent people from falling. Do not allow Takia to fall and fall all the way down and die within 4 years of diagnosis of hypertension that is treatable. It's a chronic disease. It should not kill a 36-year-old. I hope you will join me in this fight, and I think we'll take questions at the end.
Yes.
Okay.
You could hold questions. Appreciate it.
Thank you for your time.
Thank you, sir.
Good evening, large crowd that we have. Thanks for being out here. We're so glad to have your faces and voices here tonight. Dr. Jegede, it's hard to come after you. You're one of the most highly respected physicians in my world, and so it's an honor to be on this stage with you. I'm Jean Elms. It's hard to say Jean Elms. I just turned to Jean Elms on May 2nd. And so I feel like I'm forever, you're going to see on the slide somewhere Jean Workman, I'm sure. But I'm the program manager of Every Baby Guilford. A little bit about myself. Every Baby Guilford is a public-private partnership, so I work in public health. I've been in public health in this tour of duty 5 years. Prior to that, I spent 14 years in public health in adolescent sexual health. I had a brief time of about 8 years working in the national level in nonprofit work. So my world has been around infant and child health, maternal health, reproductive health my entire career. I reside here in Greensboro, have been here in Guilford County, chose to live here in Guilford County post-college. My practice husband tried to convince me to live in Hickory for a brief bit, and I said, no, that's not happening. I'm coming back to Guilford, and did, and fell in love with it. And this tour of duty in public health, working in infant mortality, it's really some of the hardest work that I've ever done in my career because of this Black maternal health crisis that we're in. And I'm a white leader leading a Black maternal health crisis, and I own that and see where my presence and attempt to use my privilege where I can and attempt to be an ally in this work. It is an honor and privilege to work alongside of my staff and the community in this collective action movement that we call Every Baby Guilford. So a little bit about Every Baby Guilford. So Every Baby Guilford, we launched in June of 2021. For 28 years at that time, we were the Guilford County Coalition on Infant Mortality, again, a public-private partnership where we partnered publicly with Guilford County Public Health, privately with community-based organizations in the community. When I stepped into this role in 2019, the disparity ratio of infant deaths in our Black communities was the same as it was when this organization launched in 1991. And the focus of the organization had been in a particular area, and when I stepped in, I said, well, I think we really need to focus in on disparity rates and not just overall infant mortality rates. And I wanted to do it in a very planful, strategic way. I don't know if you'll find it funny, it was not so hilarious to me, but when I came into the role, the health director came to me and said, the commissioners want to make infant mortality reduction a priority. I was like, yes, that's my job, I need that. And, but they want something now, like boots on the ground. They want a program. This was March, the budget was going to be passed in June, but they wanted something by April. And we want boots on the ground. What are you going to do? What are you going to do to end infant mortality? I was like, well, I've only been in my job for a little while, and I really would like to have a planful strategy about this. I just don't want to pull something out of my backside to say this is going to work, because I don't know what's going to work yet. And she was adamant, no, we've got to have something. And so I said, well, can we have a FEMR then, a fetal infant mortality review? And for those of you who don't know what a fetal infant mortality review is, it means we go dig deep with our infant death certificates to identify the why of why a baby's dying. North Carolina didn't have a FEMR at that time, and I thought, well, why don't we be the first one? And so we are. We got that position that year. But I also said when I got the position, and I think this was 2020, I said, okay, can we still have the plan to plan? I know you didn't want the plan to plan, but can we do the plan to plan? And they said, sure, yes, we'll do that. They didn't fund it, but we got other funders, and we came in with a collective action strategic planning process. And that led to launching Every Baby Guilford. Our mission is to ignite and mobilize Guilford County through partnerships and unified strategies to eliminate racial disparities and prevent infant deaths. Our vision is that every baby and family will have equitable opportunities and access to achieve the healthiest start in life. We launched in June of 2021 with a new name, mission, vision, values, brand, and we announced a bold goal that we're going to reduce disparities by 50% by 2026. That is indeed a bold goal, but I am so grateful Cone Health came up with their 5 by 5, because that's greatly going to help us achieve in our work. So I want to talk about how we got here and why we're here and the historical perspectives. So when we named our bold goal, one of the things that we named as a kind of combining all of our 4 strategic priorities is institutionalized racism is the reason why we have such high disparity rates in infant deaths. And so social determinants of health, Dr. Jegede spoke about, but these structural, systemic, and environmental factors have influenced the health of moms and babies, especially for our BIPOC communities across the nation and here in Guilford County. Between poverty among women, inadequate prenatal care, uninsured among women, we have disparities that have existed and persisted for a very long time. When we look at a historical perspective of impact of slavery and institutionalized racism on maternal health, dating back in the 1660s, women were considered who were descendant or majority of Afro-descended or Black individuals were considered property. And then we moved from 1660s, where Black women are considered property, to the 1807s, when the importation of humans became illegal, which then forced Black women, their womb became the vehicle for slave owners to create additional slaves. Can't bring them in anymore on a ship, but we can impregnate our current female slaves and then make their babies, their descendants, slaves, so that we have free labor. In 1850s, James Marion Sims and other physicians began experimentation on Black women's bodies, and much of that experimentation was done without consent, of course, and also without using any type of anesthesia. In the 1930s, the eugenics movement, and I think y'all talked about last night, this program talked about the eugenics movement, which began forced sterilization among women here in Guilford County, across North Carolina, and across the nation. Women were forced to sterilize when they were given what was considered mentally unstable. And a mentally unstable woman was defined mentally unstable if she had more than a certain number of children and not a husband at home. Yeah, you're laughing, right? Yeah, so reproductive health justice, and this ties my work back with sexual health. So if a woman had multiple fathers of babies, she definitely was considered mentally unstable and was forced to be sterilized. Think about that. Let that sink in. So, are we like in my world in sexual health? So if a woman enjoyed sex, she was forced to be sterilized. 1980s, the welfare queen and crack baby messaging among black mothers labeled communities that they were unfit to be good mothers, and so babies were taken from them. Men were put into prison, and then in the 2000s, we're criminalizing the drug use during pregnancy, which has led to so many things happening with women who are punished when what happens to their children. This is a historical perspective that, while it's in our past, it still continues to happen today, and it has impact. So from Afro-descended or black women considered to be chattel property, we devalue black women and their bodies. Dr. Jegede spoke about, we oftentimes don't believe someone's in pain because in a textbook it said black individuals have a higher tolerance of pain, so we don't need to deal with that. And then studies show black women are more likely to experiment discrimination in a doctor's office and are less likely to be believed when they report something is going wrong. Law instituting the bio-underclass creates illusion that Afro-descended or black mothers cause their children's disadvantage, suggesting that when a black baby dies, then it must be the mother's not doing enough. And public discourse about how black women having babies causes their cyclical poverty. All leads to the family policing that has happened throughout the years in black families, and having black women less likely to voice struggles. When we were trying to determine what we would do in 2020, someone on our team said, well, we've got to attack, like, I had pulled the death certificates from 2019, and I had done a very rough analysis of what causes of death had occurred in our infants. And the predominant factor was prematurity and extreme prematurity, which is a result of hypertension. And so our medical director said, well, Jean, if we need something to do, like hands-on work to do, we should create a program that works with women and teaches them how to eat right and to exercise and to take their meds and to go and do all the things that women are supposed to do. And I said, with all due respect, Dr. Bay, we've been doing that for 28 years. It's called home visiting programs. Nurse Family Partnership, tried Baby Love Plus, Healthy Beginnings, high-risk pregnancy for, I call it pregnancy care management, but it's case management for high-risk mothers. We've got a multitude of programs that work on that individual level. When are we going to stop blaming the individual and start blaming the community in which they're trying to live in? And so I wanted that groundwater approach. I did have some slides that I took out on the groundwater approach. Raise your hand if you've ever been to a groundwater training with REI. So the fish, some are saying no, so a fish lake mentality. We've been working with the fish for 28 years at that time. We needed to be working in a lake that the fish have been swimming in to ensure that the groundwater that the lake is, that's supporting the lake is a healthy groundwater, so when a birthing person then enters into that community, it's a healthier community, and that's the fish lake example from REI, done in Jean's quick five seconds. So when we launched, we looked at data. I had been looking at data. Maternal and infant health are key indicators of the health that gauge the overall health and well-being of a community. A lot of times businesses will not choose to come into a community that has high teen pregnancy rates and high infant mortality rates because they're going to look at the workforce and the potential of an educated workforce. And they're going to look at, well, what's wrong with the community if here in the United States we've got multiple babies dying in a community, what would be wrong with the groundwater there? And so this data, caveat, this data is 2021. The 2022 data is out. We're doing a big event on June 10th at 12 o'clock, Crucial Conversations. Go to everybabyguilford.org. We'll unveil the 2022 data. I started to put it in tonight, and then I thought, God, I don't want a commissioner to learn about the data from an event that I did here without them learning about it from an event that they're a part of. But I'll speak to that data in just a few minutes. We did see a decrease after launching. So in 2021, the rates did drop. They remained the same between 2020 and 2021. From 2019, it went from like 9.8 down to 7.6, and remained 7.6 per 1,000 births in 2021. So we're seeing some overall good things happening in our overall infant mortality rate. However, Guilford County is still higher than North Carolina and the United States. We're also higher than Mecklenburg, Wake, Durham, and Forsyth County, and Guilford County always fight to wear the same crown. As a result of that, we've partnered with a statewide grant this upcoming fiscal year, the Improving Community Outcomes for Maternal and Child Health Grant. We are partnering with Forsyth County. We didn't qualify, actually, to apply on our own as a county because our disparity ratio dropped 10%. While that's great news, it's 2 years of funding, so we're only 2 years into that grant. So in our next iteration, over the next 2 years, we're going to partner with Forsyth and help equip them with forming their own Every Baby. Maybe they'll call themselves that, Every Baby Forsyth. We'll breathe that to life. But you can see from the United States and North Carolina, Guilford County has always remained higher than the state and national level, consistently throughout. And then when we look at disparity ratios, what I really want to see is, in the first slide, I want to see this starting to close in its gap. And while we've seen some decline, it seems to go up and down. When we look at it from 1 year to the next, as I was getting hopeful from 14.3 when it dropped to 10.7, I remained less hopeful when it went back up to 12.3. I'm told by our epidemiologists, don't look at 1 year data, look at 5 year data and look at the trends. And so I do try to focus on this. I take this data very seriously. When I see this data, I don't see numbers, I see people. And I see human beings that are experiencing this disparity rate. And I see that this has been lasting for far too long in our community. Every Baby Guilford, when we launched, we named 3 metrics that we are primarily looking at. So we're looking at access to prenatal care. And unfortunately, we have a higher percentage of individuals in Guilford County that are Black and brown who are accessing prenatal care either through the second through later trimester. We're looking at preterm births, and unfortunately, our Black infants have a higher rate of preterm births than our Hispanic and white infants. And we're looking at birth weight, so babies that are born 5.5 pounds or higher are considered good birth weight. Low birth weight is anything under 5.5 pounds, and unfortunately, our Black families experience a higher disparity rate, both for low birth weight and very low birth weight. You can imagine a preterm birth is going to occur if a woman does develop preeclampsia, and preeclampsia occurs when a woman has high blood pressure during her pregnancy. We believe if we drive down the disparity rates in these 3 metrics that we're going to drive down the overall infant mortality rates. And so when we look at the years since 2019, from the year that I came on board and I was looking, so when we launched in 2021, we were looking at 2019 data because data is always 2 years behind. So I wanted to look at trends of what's happening. And while we've seen some positive things happening across the years, we're not seeing it enough and at a quick enough pace. So preterm births, you can see, went higher in 2021 than from 2019. Same thing for birth weight. Low and late or no prenatal care overall seems to have dropped, but for our Hispanic and Black families, it's not so much. So in 2021, we had 44 infant deaths. In 2021, black babies made up 38% of the total births in our county, but 64% of infant deaths. For every one white baby that dies, 3 black babies die in our community. So I'll tell you, in comparison to the 2022 data, we've got some good news and bad news. So come join us on, that's my teaser, on June 10th at 12 o'clock. But what we're not seeing is improvement to access to prenatal care. One of the goals that I'll have for this upcoming fiscal year is to form what I'm right now, because I can't think of another better word, a think tank of, I want physicians, I want OB providers, I want their office managers, I want our maternity care clinic and public health, I want our home visiting program personnel all sitting at a table together, and I want to start with the question of why and keep asking why. Because why in God's green earth in Guilford County, when we have a program I'll talk about in a second called Adopt a Mom that links women to prenatal care regardless of their ability to pay. We work with Cone Health providers, a private physician in High Point, and our health department clinics at a reduced cost. Cone Health is willing to take $500 for this antepartum care. So why on earth would somebody say, I can't get into care by my first trimester? I think one of the reasons is physician offices are purposely not bringing women in until their 13th week. And so somehow that gets reported, that's second trimester. I'd also like to know the answer of how is this data reported to the state that we're pooling? That's a really important question to be asking, because is it real then? I mean, is this something that's being self-reported and not something from a chart? So if someone's self-reporting this when they're in the throes of labor, when did you start prenatal care? And she's saying, well, I think it was the 13th or 14th week, but maybe it was the 12th or 11th, I'm not sure. I want to know the answers to that of why. Because here in Guilford County, we have the safety net to ensure that individuals can get prenatal care in a timely way. So our common purpose with Every Baby Guilford as a collective action movement, and collective action is a community-led process for advancing equity and achieving social change. And so we're building these collaborative solutions. We did it through a planning process. We're doing it through an implementation process where we're involving the community, everyone in the community. Everything we do, and we do a lot, and I'll show you a slide in a few minutes, my team constantly hears me say, how did you engage the community in planning it? How are you engaging them in implementing it? And how are we engaging them with some type of evaluation of it? Because we believe that when we share power, trust, resources, and effort, we can disrupt these long-standing racial disparities. We have a mantra that we believe if we collectively ensure more black babies are born healthy and live to celebrate their first birthday, that we're going to create a healthier Guilford County for all infants. I'll be talking a little bit about that on June 10th because of some good news and some not so good news on our data that we're seeing. I want to believe that, and I heard Dr. Jegede say that when we create a healthy environment in the zip code areas, census tracts that have had historical high disparity rates, when we build that up, we're building a better Guilford County for everyone. The problem is we've got to be brave enough to want to do that, to desire to do that, and think boldly with how we're going about doing that. And so this goes back to the 3 metrics that I talked about: increasing the number of pregnant individuals getting into care before the second trimester. We want to reduce the number of preterm and low birth weight births within our black and brown infants and families, and then we believe in doing so will increase the number of Guilford County babies who make it to their first birthday. When we convened our community in the collective action strategic planning process, the drivers of infant mortality based on research as well as the community dialogue was environmental and life stressors, women of color in particular not feeling empowered to be able to self-advocate, and health care needed for positive infant outcomes is narrowly defined as a result of interactions with providers rather than from factors that influence health. And then the barriers for accessibility and lack of knowledge about resources and services. So collectively as a community, we're trying to look at these drivers. We're working strongly with Ready for School, Ready for Life, other partnerships within our community that are also working in this issue. They are heavily seated at our table. So we identified 4 strategic priorities, and the community identified 4 strategic priorities, and we named them these. We put it into this fancy language of advancing health equity by addressing systemic racism and implicit bias within the continuum of care of maternal and infant health. We're centering the community with a radically inclusive community engagement process for collectively creating equitable solutions. We're strengthening the continuum of care from before pregnancy, during pregnancy, between pregnancies, post-pregnancy for equitable access to care. And we're promoting infant wellness and positive child development. So I've got a list of our programming kind of scattered in these 4 strategic priorities. Now, if my staff were here, they would say, well, you know what, Jean, amplifying every voice really could also be under centering community. And I have to constantly say, we got to put it somewhere. So we're going to put it here, but know that they can move back and forth. But this is just a variety of programs that either we implement, very few of them we implement ourselves, or we serve as the backbone entity to ensure that they've been expanded. So I'll just brag on ourselves, or maybe not, and highlight a few. So the Adopt a Mom program, we'll start with that one. It's our signature program. We've been doing it since 1991. Adopt a Mom has been linking undocumented, uninsured individuals to prenatal care in this model where providers have historically been doing the care. Up until I came along, it was at $400 per patient. Now it's $500, and we provide an ultrasound for each patient. When I say undocumented, most uninsured individuals in our community are going to be our undocumented residents. Any others in pregnancy will likely qualify for Medicaid or pregnancy Medicaid. I considered getting rid of this program when I came on board. The primary population in the program was Hispanic individuals, and when I came on board in 2019, the data from 2017 and past, the Hispanic infant mortality rate mimics the white infant mortality rate. So I said, why do we have a program that's not impacting Black families? We're investing a lot of time and energy and grant management on a program that's not impacting the population that we need to impact. I think I met with Dr. Jegede to talk about interconception care, and the importance now is not so much linking to prenatal care, but ensuring someone is passed off to a primary care provider so taquillas don't happen, and to make sure a warm handoff is occurring and she's managing any chronic health conditions, so if she becomes pregnant again, makes it to that pregnancy, then that subsequent pregnancy is going to be very healthy and not harm her or her infant. So we were talking about that. Well, can we create a model similar to Adopt a Mom, but for that primary care? And then this thing called COVID happened in 2020, and it was devastating for the population we serve in Adopt a Mom. While many of us were getting stimulus checks, they were getting nothing. While many folks in our community could now apply for food stamps who had never applied for it before, these families couldn't. Devastating. Their partners and spouses work in restaurants. They're the construction workers. There were no jobs. It was devastating. So I said, well, we're not going to pull a program while it's devastating to everyone. We're just going to amp up the navigation of how we're connecting individuals in this program to care, to which we have done. We still have issues going on in this program that we have gaps that need to be filled. We've got patients that need to be referred to diabetes management. We don't have diabetes management providers who are willing to do that at a reduced cost. I might be talking to you about that. We've got a lot going on in High Point with that. If you don't have the money to go, you get referred to the diabetes clinic, but you don't have the money to go, so you don't go. And that's devastating for your pregnancy, and it frustrates the physician providing your care. But what do? You don't have the money to go. And they're charging you, and population that we serve does not want collections calling them. And so these are real issues that we have because that takes money, and we don't have like the pot of funds that Gold United Way is here. Maybe I'll talk to y'all about funding for a diabetes program, I'm not sure. But that's Adopt a Mom. Currently, in the past fiscal year, we will have served by June 30th about 230 birthing people in the program. I'm projecting 260 in the next coming year. It did increase greatly when Biden was elected. We went from 150 moms to 230, and so we've seen an influx from immigration those barriers being released and individuals coming into North Carolina and Greensboro. Housing is another issue with that Adopt a Mom program. We need housing for pregnant women, but when you add to it uninsured, non-English speaking, undocumented, wow, high-risk pregnancy, then it becomes, I'm up at 3 a.m. thinking about where is that poor woman sleeping tonight. So we put that under promoting infant wellness and positive child development, and we put a lot of our, I really honor our home visiting programs in that space. We have expanded, I think it's up there somewhere, centering pregnancy in Guilford County. We expanded it at Med Center for Women. And I just got some data back on the first cohort that wrapped, or the first year of 9 cohorts of centering pregnancy. And the data shows that centering pregnancy works. We've got better birth outcomes. We've got better gestational age of the participants in centering pregnancy compared to the entire Center for Women's Healthcare practices. It's a very powerful approach. Centering pregnancy is group prenatal care. Individuals come together. The participants in the program at Med Center were predominantly Black or brown and, yep, that's what I wanted to say, Hispanic and or Black families. We've launched maternal mental health. There's a program called Mothers and Babies, and we brought that to Guilford County through some of our state funding. And we do some peer education programming on our college campuses, North Carolina A&T and UNCG. And then we have a health ambassador program where we recruit individuals in our community who are individuals with lived experience. We pay them and we ask them, will you share information about perinatal health? We train them on perinatal health. We give them what they need, equip them with the tools and information. They spread the information via social media, but they also do group education and one-on-one. But it's our way of doing that radically inclusive approach of saying, we believe that you would be the go-to person to share information. Will you help us spread the word? And so we do a lot of things. We had a project, Amplifying Every Voice. We collected the narratives of 27 birthing people in Guilford County to hear about their experiences with their maternal health. Some themes came out from that. We're in the second phase of that work, working with an organization, Riot for Change. And Riot for Change is digging deep within Cone Health System and currently Guilford Public Health, and then we're working to get them into Atrium Health to begin working with them. Their goal is to create the processes and opportunities for identifying the processes, practices, and procedures where bias and discrimination is showing up. Because we believe if we don't hold people accountable for what is happening, it's going to continue to happen. So that's an overview of where we are. We do health equity impact assessments within all of the initiatives that we implement, so we can continue to ask why and dig deep. So I was asked to have a call to action and things that community can do to be involved. And so what will come up is our social media. Join our newsletter at everybabyguilford.org. We've got a plethora of information that we give out each month on activities that are happening, things that you can show up to. But here are some things that I'm thinking about as an individual or a consumer here in Guilford County. If I were to see discrimination happening at a private doctor's office then while I'm there, somebody being spoken rudely to, being mistreated, I'm going to ask a question. It's going to be hard to ask to go up to the person that I just saw happening to it, but then I'm going to put them on the spot, and then I might consider, do I really want to go to that practice anymore? If we shifted power from where we're seeing the negative behavior to where we see positive behavior. I believe strongly in Cone Health, so much so I've switched my health care over to Cone Health as a result of some of the partnerships that we've seen. I was blown away when we launched and we did race equity trainings. What is it, something like 98% of your leaders have gone through REI Phase 1 and groundwater training and continue to do it, because it's not a one-stop thing, cyclical. People come in, right? They leave their job, they got to come back in. So trainings, we're like, well, that's the what. And then the so what is how do we dig a little deeper? And the now what is how are we holding people accountable? I was serving on a health equity committee with Cone Health, and this whole, from the women's service line, the women's service line was digging deep with books to read, having a little book club, so that everybody was getting educated on this. They were having open dialogue, and I said, this is so refreshing. So United Healthcare went to Cone Health practice as a result of that, switching from another healthcare institution here in town. Shifting power, that's what we want. So some of the things we're working on is to create a home visiting report card. United Way, you might be thrilled to hear that. We're hopeful to have collective outcomes of all of our home visiting programs on those 3 metrics and then some others. It's not to punish home visiting programs. We just collectively want to see how we're doing and celebrate if it's really good news. We need funders to know this to keep funding the programs. But if it's not so great news, by chance, we can convene together and say, all right, what's up? What are we doing? And how are we going to make change? We hosted a reproductive health justice training last week. Maybe it was May. May's been a rough month, but we didn't have the attendance, what I was hoping for the amount of money that we invested in this training. So I'll be finding another way to find the money to do it again. But it was one of the best trainings I've ever in my life been to, and I was the only white woman in the space. We need more white people showing up for and being an ally in this work for change to really happen. It was almost painful to be amongst my black colleagues in this training when we were going through reproductive health justice timelines of historical perspectives, and it's got to weigh heavy when you continuously hear when you've lived this experience. It's heavy enough for me being in the space, and what do we do about it? How do we make change? So we're hoping with the home visiting report card as well, one of the things that came up from that is how even in our home visiting programs, the predatory behavior we continue to utilize to get into people's homes just to check off something that it's a grant deliverable that you got to, you're supposed to meet a certain number of people. And well, what if that certain number of people don't want to have you in their home? So how can we still do this work without having to push ourselves on others? I want to do a doula report card. We've launched a countywide community-based doula program. We're only going to serve in this, we just served about 25 individuals in the first year. We only launched the matching since February. I say that's a positive thing. It doesn't sound like a lot of numbers, but doula programs this is hard work, and finding the funding and figuring out how you're doing it, and then doing the matches, all within, we work in government, so in all of the red tape that we have with all of that. In the second fiscal year of launching, we were going to serve 60 individuals. I've cut it back to 45 to ensure that we've got the funding because we didn't consider a backup doula program. But I want to institute a doula report card so that we can see overall every birth that is assisted in Guilford County with a doula, and then the births that are being assisted in the program that we've got. I want to look at the impact. Are we making a change? Is there positive birth outcomes from doula-assisted births? And if there is positive results with that, we need to sing that from the mountaintops so we get more funding so more individuals can have doula-assisted births. And I want a breastfeeding report card too. We need to know who is doing what, when, where, and how, and why in Guilford County with breastfeeding education, because there's a disparity rate of less black mothers initiating and continuing breastfeeding in our community as well. Here's the big one that I'd like to do. Dr. Jegede, I'd love for your opinion on this, but you're going to smile when I say it. I want an OB report card. We have a school report card. Families can decide what zip code they want to live in based on school outcomes. We had an OB report card that listed out, is this practice going to kill me or my child? Not in those words. But if it stated the birth weights of the majority of births that they've had, the gestational age, the percentages of mothers brought into care at first trimester versus second trimester, number of vaginal deliveries versus cesarean births, number of breastfeeding initiation when they give birth, at postpartum visit, percentages of people who come back for their postpartum appointment, and percentage of patients that are seen in that practice who have Medicaid. That's power, and that's shifting power so somebody can make an informed decision. And then for those who aren't even looking. You can shift your care when you see the outcomes to where you see outcomes that look good. Because that's how we're going to shift the power from the provider who's historically had it to the consumer who desperately needs to make that change happen. So at Every Baby Guilford, we are doing a lot of things. We need the community present. I don't know if we're ever going to get to my slide that has the information, but maybe not. I've got brochures here that has our contact information. Please join us. We have a community action for healthy babies that meets quarterly. I believe our next meeting might be in June, late June, I think it is. Community Action for Healthy Babies is for individuals like yourselves who are interested to get involved. We typically meet between 12 and 2, sometimes in person over lunch and sometimes virtually. And it's for the community to come together, give us input into our programming, but also find a way to get involved. We'll have an event in September for Infant Mortality Awareness Month, and then we'll have an event in October for Pregnancy Infant Loss Day called Every Baby Remembered. That typically has been held at LeBauer Park on October 15th. So things to get involved in the community. Join us at Community Action for Healthy Babies to dig more into these things of how you shift the power within what's in your realm and in your ability to do so. Thank you very much.
So we're going to move into the engage portion of the evening. And what I want you to do is take the next 3 or 4 minutes, pair up with someone in the audience that's nearby with you, and just talk for a few minutes about what you heard. Is there anyone who is brave enough and wishing to share some thoughts or comments about what you've heard tonight?
I was just mentioning that where do we start, right? Because there's a lot, even just within, maternal fetal, health. It's very interesting to hear, but obviously there's so many realms. I actually work in diabetes care, so I found it, really the parallels, right? And you even mentioned diabetes as one of the things. So, some of the things I talk to hospitals about is, who they will offer CGM to. And it's like, well, the insured, we know they're going to get coverage. And to me, I'm like, well, that's really putting a block on a lot of patients that could use this type of, care and self-management. So it's really, it's enlightening to kind of see, that it's being seen, especially by health systems and community health organizations. I myself came from public health, and it's been a while, but it's like all flooding back as just in this conversation. But, just so in my head, I'm like, what are the small things we can do? And I hate to say because there's not an easy button, especially in healthcare, right? So what is something we can do now, even not necessarily in healthcare or in our health systems, but what can we do now? That's something that's simple to open. And you mentioned, for continuum of care, that's what I'm really interested in. But you mentioned the education, and I think hospitals are doing that. But I also think, providers, they don't always know what to provide a patient and all, so I'm curious what we can do, what programs are there and how we can educate, because it's hard. There's a lot of resources out there, but there's a lot of, the clinicians, there's doctors, nurses, social workers, what can we do and how do we engage that to kind of make this a whole spectrum of health? I know that's a really loaded question, but that's just kind of what came to my mind. How do we kind of do something simple now to kind of create that better care in the hospital and that continuum of care for patients when they leave the hospital?
This made me think back to when I was working at Cone Family Medicine and had a Hispanic clinic for about 10 years. And I became aware of the Latina paradox, which is, of course, newly arrived Latina patients have the best birth outcomes in the country. But the thing I observed in my clinic is I actually saw people's health worsening as they were here and gained weight, developed diabetes and hypertension and other. So it's just another, I guess, reminder that we're in a relatively toxic environment. In some ways, you have to learn how to, navigate your way through that and keep yourself healthy. And that these social determinants of health, another reminder of how important they are.
I'll share something real quick while I'm getting over here. my daytime job is a transportation planner in transit, so I was glad to hear someone finally mention transportation. But also from our very first talk, those redlining maps match the maps that you show. So you can draw a line there.
Great talk, both of y'all, with all the information and background and research that's going on. It's really enlightening. I'm curious why Guilford County is highest in infant mortality, and I'm not going to ask you to answer that, but it is something to wonder about. But do you think if you had more funding, can you make more difference? Is it money that would change the situation, or is it all the others? Would funding help, more funding for your programs?
Yes, both of you had great presentations, and so my mind is racing. And Dr. Jegede, you said a word that sticks with me, which is messaging. So I think of public health messaging first when I hear that, but also with the chart that you showed with, I think, the social determinants of health, some things sometimes feel contradictory, or it's just too much, because if there is public policy and the social norms or whatever, at the bottom of that chart, that are a big piece, and we keep saying with social determinants of health, clinical care is a piece and it's a small piece. But what feels contradictory is that between individual and population health, it's like there's this population or cultural stuff with the policy and the social stuff, and then we tell people, go talk to your doctor. When people don't have doctors, for whatever, I don't have a PCP. And you would think I would if you knew me. And so, and the dynamics, power, I think I've heard Eugene talk about power dynamics in an appointment. And so there's all this power dynamic, and just as an individual, talk to your doctor, but there's so many things that block people to even get to that point and feel comfortable to have those conversations with a nurse, doctor, receptionist, in a doctor's office. So please speak to that.
Yeah, anyone else with a thought or something to share, and then we'll let them get to these questions. All right, well, let's go back first to where we started here, and sort of just, because it's related to the second question a little bit. We're talking about more funding, what can you do? So beyond maybe what you've said, or to emphasize what you said, sort of both of you take those questions on.
Maybe I should just start from the funding issue. Always good to have funding, always good, because there are so many programs that will help to at least take care of some of the social drivers and the outcome in all those drivers of life expectancy, infant mortality being one of them, diabetes, hypertension, under cardiometabolic disease, and then you have the other ones like cancer spreading and all that. If we have funding, we can do more. But if you really want to impact health inequity, I think we need to go upstream. By the time people develop these issues, diseases that we talk about, and having poor outcome because of them, it's not really that people don't want to take care of themselves. And it's not that, when they come to the doctor, that we have all the solutions. Because environmental factors is there. The structural racism that we talk about is there. We're talking about political drivers of health. In one of my discussions with the city officials about how can we help some part of East Greensboro have more access to grocery stores, like the regular, I call them regular grocery stores, when you see them in other places, like, Walmart, like Paris Theater and all that. But they told me that there's a policy, and I don't know if it is city policy or grocery store policy, that there needs to be a certain rooftop numbers. The number of rooftop determine where they go, and that there is not enough rooftop in certain part of East Greensboro. That's why they're not there. So what's available to them?
Family.
Popeyes, Family Dollars, Dollar General. and convenience stores where they sell alcohol and cigarettes. So you now see someone who don't have transportation, can't make it to West or Northwest Greensboro. They go to what is available to them. So when you say to me, when they come to me and say, you need to go eat healthy, you need to eat more vegetables, eat more fruits and all that, it's not available. Or when it's available, they can't afford it. So we really need to go upstream. Another point I really want to make very quickly is in zip code 27406, which is part of East Greensboro, the population is about 46,000. From our own data, 21,000 of this population have been to the emergency room at least one time in the last 3 years, but have not been to a primary care doctor. 21,000. Another statistic is from age 18 to 44, all the people that have high blood pressure from age 18 to 44, only 1 in 5 actually know they have high blood pressure. So that when they are now 40 something, 50, hypertension is already going in 4 out of 5, and they are coming to the clinic after they've had a heart attack, or they've had a stroke, or they are on their way to dialysis. Those are the kind of things that if you go upstream, screen everyone, let them know what they don't know, and connect them to care, that is primary care. Now we begin to have that conversation. Oh, by the way, you have pre-diabetes, before it becomes diabetes. Oh, you have blood pressure that is probably going to be problematic. Let's start taking this medication. This is what you need to do. Education, you know. And I believe that's how we can impact this. When there's a lot into this, funding is great, but we really need to make sure that people are screened, connect them to care, and let them follow with the primary doctor. There is a statistic again that says if you have a primary care doctor, you live 2 years longer than somebody who don't have a primary care doctor. And there's another one that also says if you have a primary care doctor that looks like you actually live again longer than those that don't. So it's a lot of things I can say about him, sir.
How many primary care doctors are in that zip code? 0?
No. Yeah, that's another problem. It's a healthcare desert. They don't have the closest healthcare system is the emergency room. Yeah. That's not good.
I don't know that there's easy answers. As soon as you said the number of rooftops and we built a grocery store. So my question, if I was on that committee, is to continue to ask why, but why, but why? Why is it then okay that Dollar General or Family Dollar builds in that neighborhood, but not Food Line? Not a Harris Teeter, but a Food Line or Walmart or Marketplace. They didn't pay me to say that, they're just cheaper, a little cheaper. Anyway, to your question, and I think Dr. Jegede says this is a Jean thought. When a woman grows up, when she becomes sexually active, she goes to a family planning provider. And that family planning provider may or may not put her on contraception of her choice. So she goes on contraception. When she's ready to have children, she stops taking contraception. She gives birth to her children. Typically does not go back to any other doctor, but maybe a family planning doctor. And I think a lot of times there's a myth that the family planning doctor is taking care of primary care health needs. There's an opportunity in the family planning doctor's office to educate that patient that yes, I'm taking care of you in this way, but your blood pressure is a little high. I'd like to do a warm handoff to this doctor. They're in this practice. It's going to be here, and then do as we did in the presentation walkthrough. Do you have the transportation? Do you have what you need for that? So that we can get them linked. If they're in, when you're in a diabetes education session with a patient, are you talking to them about preconception health and reproductive life planning? There's an opportunity, like a no wrong door approach, to be talking about men and women about the whole reproductive life plan continuum, so that at any stage someone is going to become aware, oh, I do need to be thinking about that. You are admitting you don't have a primary health care provider, so there could be underlying issues that you don't even know about without having that blood work, done. And I just think that awareness is so important. There's not easy answers. I would ask, I don't know where your practice is, what you do and how you do it, but do y'all offer up at least 10 slots to someone who can't afford to come in with insurance and your care just covers, your practice just covers that? I just made that up. I don't have a clue if that's even feasible. Sounds good though, right? Money, do we need money? Yeah, we need money. We need money for everything that I just said. We're paying doulas $1,200 to provide birthing support. That's not even enough, but it's more than what Medicaid's gonna pay, so we thought it was gonna be great. Did you hear me? We're serving 45 people with that $1,200. 45 individuals will get served with that with the total amount of funding. So yeah, we need more funding, but before I apply more funding, I want to see that this is working. I don't want to just put something out because right now that's the trend that we do. I want to make sure it's working. So yes, we need funding, but we need funding that's also thinking about the upstream approaches and the asking of the whys, us getting into spaces and not being afraid to say, but why? Why can't we build a grocery store in East Greensboro that's going to support these families? This zip code data thing, it's been sitting heavy with me since the reproductive health justice training last week. I've been looking at zip code data between High Point and Greensboro my entire career when I worked in adolescent sexual health. And guess what? Teen pregnancy rates are also the highest disparity rates in those zip code areas of 2740605, 2726260, and High Point, only certain areas, and I think it's 27262, not the whole zip code area. We've been saying this for a long time, and nothing's changed. Why hasn't anything changed? But why haven't we created better communities? Like, we sit around and we talk about it. When are we going to do something about it? And so how can we get ourselves asserted in those spaces where we're talking to chambers, we're talking to the leaders. We don't have to hold the goal in order to make the change. We need to sit and have our voices spoken up. So think about that when we make our at elections and who are we voting in, and are they thinking about the high disparity rates and actually doing something. So there's no easy answers in this at all.
So, out of respect of everyone's time, thank you, Dr. Jegede and Jean, for being here and sharing this amazing information with us.